Welcome to the Art of Pilates. I'm Louise Taube, principal trainer. I am a studio owner and a Pilates teacher, and I train teachers as well. If you'd like to connect with me, you can visit my website for teachers at taubepilates.com. If you're wanting to check out my studio, it's louisetaubepilates.com. And if there's a topic on the podcast that you'd love to hear about, please let me know. And now for part 2 with Charlotte Ganderton and Gluteal Tendinopathy. HRT is now actually called menopausal hormone therapy. So it's now called MHT. So whenever we say HRT, we're really talking about menopausal hormone therapy.
That will really cause discomfort in someone who has a reactive angry tendon.
That's really hard because a lot of my older clients, I want to practice balancing with them because they need to get their balance. So can we stand in tandem stance or we can't because that's cross-legged?
That's cross-legged too. So if you're working
stand, maybe eyes closed with the legs together.
Yeah.
Or do we have to have a bit apart with the legs?
That would be ideal, yeah, apart, a little bit apart. But often I think you raise a really interesting point there, and I think potentially it's sometimes a bit of a misconception in the public sphere. Oftentimes people come in and say to me, oh, my balance is terrible. They may not be elderly, they might be 20 and saying this same complaint. And I think we have to be really sure that it's actually their balance that is impaired. So I love your exercise, and I don't discount that exercise as well. And it's something that I give out to patients because their balance is impaired. But we have to just make sure it's their balance and not the fact that they have poor muscle function. That's meaning that they can't stand, say, on one leg because their muscles just simply aren't strong enough. So I think in the elderly group or middle-aged group, definitely, there might be a component of balance. And that might be not helped by, say, maybe they've got poor vision. That can affect our balance. So trying to sort of problem solve as to what's their biggest driver of their balance issue. Are they genuinely unbalanced? Or should you be getting their strength up through double leg exercises, progressing to single leg, and then challenging balance components? So you're right, things like your eyes closed or changing their stance or putting them on a foam mat. So if they're sore, yes, I would be avoiding those things. And sometimes you really have to take it back to the bare basics, and then you can become a bit fancy once their pain has settled down.
What if someone's had gluteal pain at the side for just a really long time? Like if it ends up being chronic, is there anything we can do?
Yeah. Absolutely. And oftentimes it's actually going back to the basics and almost starting afresh from really targeting those aggravators and trying to come up with an alternative of how someone can achieve a task. So oftentimes we call these recalcitrant presentations where they come back and they present very similarly. They might rehabilitate and then they have another pain flare. It's common. And people need to be told that it is a recalcitrant condition and it probably will come back. But they need to have the strategies to understand why it's potentially come back and then go almost through their checklist of, okay, back to double leg exercises, back to avoiding the stairs, and almost go to the bare basics quickly, get control of it, and then they can bring back in those more challenging activities. So a good full reassessment would be the first one. The second one is, have they actually committed to an exercise program, and has the exercise program been appropriate for the individual? If it's been around a long time, it's worthwhile having another pair of eyes on it. So it might be that they go and see another practitioner, whether it be a physiotherapist, whether it be a sports medicine physician, sport and exercise physician, someone who can, I guess, give a really thorough assessment, but a fresh pair of eyes, I think is nice. Even if they have a really good practitioner that they're comfortable with, I think that's important. And it's really good from a therapeutic alliance perspective and being on the same page. But sometimes you can get a bit close to the topic as a therapist and sort of they just, Betty comes in again and you sort of start where you left off. But if Betty, attended a brand new session with a totally fresh pair of eyes, they would start again. And I think sometimes as a clinician myself, I think to myself, oh, okay, well, this person isn't going along the trajectory that I would expect. I'm going to get them in for a longer appointment and we're going to start again.
Oh, wow.
You start from the beginning, because have you missed something, or should you get them in with a colleague? Sometimes I'll get a colleague to see them. Sometimes I'll refer to a sports medicine physician through their GP, of course. So I think it's very individual, but yes, it does tend to hang around for a while and it can come back even after rehabilitating. But the stronger they stay, the better. They can obviously investigate hormone replacement therapy if they're a female. It does happen in males. It's not as common. They can also investigate forms of injection. Injections are a bit controversial in the tendon space. Cortisone is a cytotoxic for tendinopathy presentation, so it can actually cause an increased risk of rupture. So as a clinician, I do try and avoid cortisone-based interventions.
Is it rupture? Do you mean like rupture, like tearing?
Yes.
Oh my
Yes,
God.
that's right. So cortisone is fantastic from a pain reduction perspective in the short term. When you look at studies, they often have this, huge improvement. But when you compare long-term outcomes, there's often not a lot of difference. If they compare cortisone to, an exercise-based intervention, we get some education. It definitely reduces pain in the short term, though. So oftentimes people will jump to that as an option, and they may have a reduction in symptoms, but it does actually increase the risk of it rupturing, which is not ideal. Yeah, it's not ideal. So I try to, it's not it's not within my scope of practice, really. We're not taught injection therapy.
Yeah.
We don't do any injections. So, people ask, I just explain to them that there are risks. They may get a reduction in their discomfort, and sometimes people are willing to take that risk. Can't tell you the exact rupture rate, but it certainly does increase the likelihood of future problems, which are probably worse for you. And then, of course, there's other injections as well that are offered by sports physicians and arguably orthopedic surgeons as well.
Wow. What if someone really, really loves running? Because wouldn't
Yeah.
that be an aggravator? That would be because you're going from one leg to the other. So
Yeah,
that would be
definitely.
compressive. It's like,
Yeah.
do we have
So,
to, what can you do instead? Say if you need it for your mental health, what are we going to do if you can't run?
Yeah, it's really tricky. You're throwing a few curveballs at me because it's a reality, isn't it? These people do come through our door. Depends on, again, it all depends on, their goal. So if their goal is running, if they can, say, for example, tolerate double leg skipping
Yeah.
in the one spot, then keep them skipping,
Okay.
because we don't want to take them out of activity completely, because that reduces what we call their capacity. So you have to sort of assess how much capacity has this person got in their tendon.
Do you look at the jump rope, like skipping,
Yeah,
but
like
landing on 2
skipping.
feet?
Yes, yeah. So if you think about, okay, well, what can this person do to keep their discomfort at a minimum, and then try and keep them doing that amount, because you want to keep their tendon's ability to do those activities as much as you can.
Yeah.
So if someone's coming to you with this problem and they're running, they're probably on the lower spectrum of problematic.
Yeah.
So sometimes you can tweak. It might be just a matter of tweaking how far they run. So they might say to you, I do park run, and every time I hit this, particular tree, that's about the time my pain starts. So get them to run to just before the tree.
Yeah.
And either stop and or at the tree, then rather than running,
Yeah.
they might do some skipping on the spot.
Oh, wow.
So they're not actually transferring from one to the other leg. You could some people have a look at their running mechanics. So the further you stride out, the more your pelvis has to sort of work to stay level. Yeah, you might get them to reduce their their stride length. And so they're sort of almost like running under their body. So they're keeping everything in close. Some people benefit from that. So it really depends on the individual, their goals, the capacity of that tendon to take on the load of whatever activity they're doing, and then how debilitated they are. So there's no, other than taking their word for it, subjectively, at the moment, there's really only one main outcome measure that looks at gluteal tendon pain, which is the Visa G. So it's the Victorian Institute of Sport Australia Gluteal Tendon Questionnaire, which I was involved in the development and publication of. But it needs to improve, like there needs to be a better one. So it's the best thing that we've got out there. So I would encourage people to use the Visa G to have an assessment of how impactful the condition is on the person, then do something. So maybe change their loading or start them in a specific exercise program, and then, 8, 12 weeks later, do the questionnaire again and see whether you've started to make any change to their number or their score. The other thing we need to work on, obviously, is like what I've mentioned, calf and quad strength and sort of kinetic chain strength and lower abdominal strength. We do need to increase the strength of the hip. So the supported hip hitch, and we've got some evidence for in our research. I still use a side-lying hip abduction, but I do it in a really short range. I'll often put pillows between their legs to support it. So say, for example, the left one is affected, we'd lie on the right hip and then put pillows between the legs. So it's not your top leg's not coming across your body.
Yeah.
And then from there, you're doing a small sort of hip abduction. That's quite nice as an entry level exercise if you can really make the range quite small and make them initiate their bottom.
Yeah.
So sometimes I get them to do like a little bottom squeeze before they lift.
We're having them in slight hip extension to do that, like slightly
So
back
I think
abducting.
so in reality, you want them pretty neutral, but oftentimes I'll cue some hip extension because it makes them use the glute. And in reality, they end up being quite in a neutral position. But you do want to
But you're
stop
not
the
turning
kick
the leg in.
forward. No,
That
you don't
won't
need
help.
to turn the leg in. Just keep it nice and neutral's fine. So that's a good exercise if they can tolerate and they only have it on one side.
So you only do it on one
if
side.
they
You wouldn't lie on the sore side to do the other side.
Correct. Yeah, if you have only one side that's sore, just keep the sore side up and then choose an alternative for the non-sore side. So you could do a hip hitch on your non-sore side.
And now a word from our sponsor, Taube Pilates. If you're interested in moving well and staying strong as you age, I've created an active aging ebook just for you. This 28-page guide is designed for adults 60 plus, Pilates clients focused on healthy aging, and Pilates teachers focused on working with older bodies. Inside, I share 8 essential exercises to support strength, confidence, balance, posture at any age. You can download it free in the link in the description. Move well, live strong.
And what exactly do you mean by a hip hitch? Is that where you
So-
shorten the hip towards the rib cage, or
Yeah, so
do you
if
keep that
you're-
length?
Yeah, you essentially, the way I describe it is you're holding on to something to reduce the balance.
Yeah.
You're transferring your weight onto your affected leg. So say your affected leg is left, you're going to transfer it onto your left leg.
Yeah.
And you do that by lifting your right foot 1 centimeter up.
Okay.
So I'm not talking about a huge hitch where you're changing sort of your torso position.
Yeah.
It's just literally stand on one leg and lift the contralateral, or so the opposite leg, up 1 centimeter. And the reason I say 1 centimeter is that it doesn't really change pelvis level much, but it allows transfer of weight onto the affected leg. So you're getting it, when we looked at it in research, we looked at intramuscular electrodes using electromyography. And that shows us how much muscle activation is occurring at the gluteal muscles. There was a needle in each muscle. And we got really, really high levels of muscle activity out of the gluteus medius and gluteus minimus during that hip hitch exercise. So it tells us that by loading a leg in a single leg, taking away the balance component, because tendons don't like to be unbalanced, we elicited lots and lots of muscle activity. So it's a really good exercise to strengthen those two muscles which are muscles we need to function.
Wow.
Yeah,
That's really
right.
interesting because it's so close to being standing on one leg, but it's not quite the same thing, is it?
Yes. So it's standing on one leg, taking away the balance component.
Yeah.
Yeah, you want to be stable. So holding onto your trap table, holding onto the wall. Like I was often think of those filing systems, the old school filing systems with the drawers.
Oh, yeah.
You put your arms sort of on the top of that and do it on the filing cabinet. That's what they're called. Use the filing cabinet for balance, or your windowsill or something
Yeah.
like that. Just take away that balance component. And if needed, put a little bit of weight through the arms as well, so that it's transferring weight to the single leg, but it's perhaps not the entire body weight.
Yeah. Can it be mistaken for hip arthritis where people have such terrible hip pain where they're like, "Oh my god, I need a hip replacement. I've got such terrible pain." Does it get mistaken for that
Absolutely.
or it doesn't?
No, 100%. It's the greatest, I guess it's the biggest differentiating diagnosis between someone who comes in with hip pain. It's very similar to lateral hip pain. Oftentimes, though, the pain location is slightly different. So generally with the tendon ones, it's very much on a focal discomfort on the outside of the hip, and it's over that bony prominence. You
Yeah.
can have some discomfort down the side of the leg, whereas hip osteoarthritis can be at the front, can be at the back, can have what we call a C sign. So people generally grab the side of the hip. So they're sort of holding the whole hip.
Yeah.
And the arthritis can refer sort of to the knee, for example, as well. So you can get some interesting referral patterns, which can become quite confusing. But the biggest question from a clinician perspective that differentiates the two diagnoses, or more likely arthritis, they'll have difficulty doing their shoes and socks up because they can't reach, because they're stiff. Whereas the people who have tendon pain shouldn't have any restriction in their ability to do up their shoes and socks, but they might find it hard because it's painful.
Oh, I see.
So that's the biggest differentiator. Can you do your shoes and socks up? And then if you can't, what's your limiter? Is it
Yeah.
the ability you can't actually get down there, or is it pain? Now, it's not to say that these two conditions can't co-occur. So you can have hip arthritis and you can have tendon pain in the same person.
Oh, no.
It doesn't necessarily change the exercises like significantly. You still fundamentally need to be strong around the hip. You need to have strong hip extensors, hip rotators initially, and then you can bring in hip flexors later. Hip flexion can sometimes be a little bit aggravating. So it might be something we'll lead to later. But whether it's OA or it's osteoarthritis or lateral hip pain, you still need to be strong
Yeah.
around the hip, and you still need a strong kinetic chain. Kinetic chain being, your thigh, your calf. You need to be strong through your foot to
Yeah.
propel through your foot when you're walking. So whether you have one or both may not make a humongous difference in the early stages of your rehabilitation. However, one may require surgery if they need a new hip, but that's a whole nother question altogether.
Yeah. And so can you get the gluteal tendinopathy if you do have a new hip?
You can, yes, because when you have a hip replacement, depending on the prostheses, it can change the angle at which so if that's your femur bone or your shaft, and that's your neck with the ball at the end, it can alter the angle of where your tendons come down to insert.
Oh.
So that can actually potentially then change the way that the tendon gets loaded. So it might get more squashed, for example. So it can be a prosthesis kind of driven presentation. Or arguably, you could say, well, maybe because they have a better functioning hip, they're doing a lot more with the hip than they ever did before. And so it's actually a loading change. So
Yeah.
they've gone from not doing much to doing a lot. And so the tendon sort of says, well, hang on a minute. You haven't made me walk upstairs for 9 months, and now I'm walking up all these stairs. So we can't blame the prosthesis, but whether it's chicken or egg, it is associated post-replacement that we can see this condition occur.
And what about going back to the idea of someone who loves to run? What if they got really soft shoes? Would that help or that doesn't help?
So good question. So the only sort of footwear knowledge that I have, been involved in a study that looked at people without pain. So these were not people with gluteal tendinopathy, and they put a shoe insert into their shoe. So they supported the arch a little bit, just one off the shelf, like nothing custom made. And what we saw was a reduction in the muscle activity of the muscles that are involved in the condition. So gluteus medius minimus, for example. Now, that might sound a little bit worrying that you think, oh, I've put this support at the foot and now my muscles aren't working well. But the hypothesis was, okay, if you put something in someone's shoe, you reduce the activity of the muscles that were causing pain. Maybe it's actually a pain management strategy to use a little foot support for a short period of time while you change other things in your life that were aggravating. You get stronger calves, you get stronger quads, you do some bridging, you do some activities to strengthen you up, and then you get rid of the orthoses. Now, there was then some further study done in the same concept in a group of hip osteoarthritis patients, and they had a similar finding. So it would give an indicator that if you change footwear, you are changing the load through the leg, and it does have an impact on the foot, the foot, but also impact on the hip. So I can't say what would necessarily happen if you went and bought soft shoes, but if they were really like pillow soft, you could arguably say that it's sort of destabilizing the foot. I don't know whether I would assume that would have ramifications for what happens sort of up the leg. But my narrative to people generally is keep your footwear relatively consistent and make it comfortable.
Yeah.
So if someone is in, someone says, oh, I wear a Nike, a Nike I changed to an Adidas. I said, well, why would you do that? Is the Nike comfortable, or whatever their shoe they're wearing, is it comfortable? And they say, well, yeah, I love them. They're really comfortable. We'll keep them.
Yeah.
Or I wear, a shoe from Kmart and I love it and it's great. Like, great, keep your Kmart shoe. Like, it's all about what's the relevance? What relevance does that have on the patient's presentation, rather than, going down to the nitty gritty of, oh, well, if you moved your shoe 3 degrees this way, it will have this effect. I think it's too hard to quantify that.
Yeah, that's true.
Yeah.
Well, we've almost run out of time, and I've just loved chatting to you. I think I've only got through the first 10 questions, so I've got another 30 questions. So we'll have to make another time in 6 months or something like that, because I've learnt so much. You've done so much research as well in so many different areas. I didn't realize you'd done so much, but it's been really inspiring.
Certainly keeps busy.
Yeah.
Yeah. And I still think it's so important. Like, I actively am a clinician. As you said, I'm at Alphington Sports Medicine, and I absolutely love it. I love treating patients. I love seeing their outcomes. But in the end, they have to commit. And some people come and see me and say, oh, you're going to be the one that fixes me. And my response is, no, I'm not the one who fixes you. You're the one who fixes yourself. And I'm going to facilitate and help you in your journey. But I'm not the one that's fixing you here. I'm not the one that's telling you to go to the gym or do your walk. Or I think so much comes down to internal motivators and identifying how we stop the barriers to people getting better.
Wow.
And but if people come in and are willing to apply themselves and are willing to really start afresh and go again, then I think they're much likely to have a better outcome.
Wow, that's fantastic. So if people wanted to find you, to chat to you, or just to connect with you, or just look at what you're actually up to next, where would they do that?
Simply if they Google my name, so Charlotte Ganderton. I'm also on the Alphington website, as well as, I'll pop up like at tertiary institutions. I've written a couple of articles for The Conversation, which sort of translate what I've done in research in my career into a really digestible format rather than being too academic and too technical. So The Conversation would also be a good place to find some basic information that gives clear strategies for people with hip pain. I've actually got one about to be released, so with my colleague, Dr. Joshua Heary. So keep an eye out for that. And yeah, there's plenty of ways to contact me, but probably jumping online's the easiest.
Yeah, that's what I did. I just Googled who knows about hips, and it was you at the top.
Oh, there you go.
Thank you
Thank you very
so
much.
Thank you so much for listening to Art of Pilates. I'm your host, Louise Taube, principal trainer as recognised with the PAA, studio owner and Pilates teacher. To stay connected, please subscribe to my mailing list via my website, taubepilates.com. And if you've loved this show, please give me a review. I'd love a Facebook review or a Google review. It really helps to support me and my business and this podcast. See you next time, and keep moving with intention.